And just for completeness, I get funding from Grail, which is a large company that develops some of these tests to detect cancer, and through the university have research funding from them and other companies that are active in this field. And I just want to be open and transparent about that. So what's the problem that we're tackling here? Well, most people know about the 2-week wait pathway, which is the system that we've had running for over a decade now to try and diagnose cancer as quickly as possible, where people go to their GP with a number of symptoms that might be cancer, but usually aren't, but the risk is sufficiently high that they go into a rapid diagnostic pathway, which lasts 2 weeks, hence the name, that culminates in the diagnosis of cancer or not. But even with that in place for over 10 years, only about 4 in 10 cancers are diagnosed in that way, with about another quarter diagnosed through GP referral into other services, but not rapid diagnostic services. And then perhaps more worryingly, about 1 in 5 cancers diagnosed in the emergency setting. So with symptoms that have brought people to A&E or other acute care settings. And usually people who present in that way have a more advanced cancer, and time can be shorter in those circumstances. Now, this is a problem that affects different types of cancer differently. And you'll see that I'm using statistics prepared by colleagues at Cancer Research UK from the last 5 years or so, but these are pretty up to date and predate the pandemic. So give us an idea of what things look like without the impact of the last 2 to 3 years. So for some cancers, it's not a big problem. So skin cancer, melanoma, because it's on the surface, we're usually diagnosing things over here on the far left-hand side at an early stage 1 or 2, with only a minority at stage 4. Similarly with breast cancer, where there's an active screening program. But if we get over here to the right-hand side, we see that particularly cancers in the gut, the pancreas, the stomach, the gullet, we've got a big problem here, with a lot of people coming to attention only after the cancer spread away from the original site. And in those circumstances, particularly with pancreatic, stomach and gullet cancer, we don't have brilliant treatments. So that has an impact upon how long people live after diagnosis. And just to put that in more detail, just want you to concentrate here on the esophagus panel in this quite complicated picture. So you can see that a minority of people, these bars here, are diagnosed at stage 1, with the majority at stage 4. And then if we look at the 1 here and 5-year survivals, you see that those fall off very, very steeply if we find people when the cancer spread to other organs, compared with if we catch it at an early stage, where the outcome's still not brilliant, but we're expecting over half of people to survive 5 years. So that sets us the challenge for early diagnosis. The idea being that if we can detect things at that early stage, then we can improve survival and diminish the burden of treatment for patients. So just to summarize that, there are just under 400,000 new cases of cancer every year, and about over 100,000 of those are diagnosed at stage 3 or 4.
They won't start on Thursday on Friday.
And as I said earlier, about 1 in 5 cases diagnosed through emergency presentation. The other thing I'd like you to bear in mind in talking about what we're doing with the blood tests is that if you go down that big pathway where we diagnose 40% of cancers, the 2-week wait pathway, then only about 4 to 6% of people who enter that pathway turn out to have a cancer as the explanation for their symptoms. So we're doing an awful lot of tests on people to find cancer in the minority. And that's not a plea to not investigate those people, but we do need to think about how we can investigate people differently so as to make the best use of resources and not put people through invasive investigations when the probability of a serious diagnosis is quite low. So when we think about researching things, and multi-cancer early detection tests in particular, which is the jargon name for these blood tests that I'm going to talk about, then there are lots of different ways that we can tackle the problem. One way that we know we can do to diagnose cancer earlier is to develop screening programs. So we have them in breast cancer, in bowel cancer, in lung cancer, in cervical cancer. And that's one way we can test all or a proportion of the healthy population and look for early cancers in that way. And that's quite an effective way of picking up early cancers. It comes with its downside, which also applies to the blood tests that we're talking about today, in that there's some concern that some of the cancers we identify won't amount to much. And there's that concern about over-treatment, that we're finding things that aren't necessarily important, even if they meet the classical definition of being a cancer. And there's a particular example of that with prostate cancer, where using the PSA test, we can find lots of prostate cancer. But what we're less good at doing at the moment is working out which of those cancers is going to cause trouble further down the line. So the other way in which we can attack this problem is to concentrate on people with symptoms and to do something different there. And some of that's about public education and about making sure that people who have symptoms, even if they're relatively non-specific, bring them to medical attention as quickly as possible, notwithstanding all the problems that we hear about in the press about accessing healthcare at the moment. But the other thing we can do is make sure that when we have these symptoms brought to our attention as healthcare professionals, we can act very, very quickly and also lower the threshold at which we act in order to make sure that we diagnose the problem earlier, and in particular, in this case, diagnose cancer earlier. So what are these blood tests? Well, all cells in the body shed DNA when they die, and some of that ends up in the bloodstream. And so these blood tests are built upon what's called circulating tumor DNA. And that small fragments of DNA, as shown here pictorially, that are present in the blood and specifically in the plasma non-cell component of the blood, and that we can detect. Now, not all circulating DNA is tumor DNA, some of it's from normal cells, but handily, there are important differences between tumor DNA and normal cell DNA that we can exploit in developing these tests. And what the tests do is look at the size of these fragments, look at the composition of these fragments, their A to T and C to G components, and then even more importantly, look at what's called the epigenetics. Now, the DNA is our genome. It's the blueprint for all of the proteins that get produced and make us who we are and make our cells behave in a particular way. What's perhaps less talked about is the epigenome, which is the additional layer of fine tuning that decides how much of a particular gene is expressed in a particular set of circumstances. And that's often done by methylation, so chemical changes on the bases in the DNA, and then other changes in bigger components around which the DNA is wrapped. And studying those has proved to be the major technological advance in this field, because what it does is it allows us to be clear which bits of DNA in the blood are tumor DNA. And more importantly, we can use that information using heavy computing power to identify not just that there might be a tumor on board, but to also predict where in the body that tumor might be. Because as you can imagine, if we're taking a blood test, that might tell us, yes, there's a problem, but it's not very good at telling us the geography of that problem, where it might start. But epigenetic information has made a big difference here, so that when you do a ctDNA test for a cancer, we can get a report back that says cancer signal detected, and here's our prediction of either the likely place it started or the top two, which can guide subsequent investigations. Now, this is a very, very active field. So there are lots of different companies in it, all with new technologies in development. I think what the difference is in the arms race in this particular setting is it's no longer about what we can measure in the circulating tumor DNA, although there are some clever chemistries, including one that's been developed here in the Ludwig Institute, that are making a difference there, but rather the unique property of each test is the ability to make sense of it using large-scale computing power to bring that prediction of where the tumor might be. So these are now being tested at scale in the clinic, and I'm just going to talk briefly about a couple of those trials before talking more generally about what the implications of the two settings in which we're using it might be. And my disclosure is important because the test that's being used at scale in the clinic at the moment is one developed by Grail. It's called Gallery. And there are two trials that are being used in different settings across that diagnostic pathway that I talked about. The big study that's been all over the press in the summer is called NHS Gallery. And this is a screening test. It involves the healthy population being invited to have a blood test. And there's about 120,000 people part of this, and looking at what cancers we can pick up with those blood tests, and try to work out whether by repeating the test in the same population over time, we can start to move the stage at diagnosis earlier so that we're picking up the cancers earlier. And the hope is through that, being able to treat them more effectively. The other trial, which is run here in Oxford, is called Simplify, and involves a number of centres around the country. And this looks at people who've gone to their GP with a symptom that gets them into the 2-week wait pathway. And what we're doing there is looking at how the test compares with the gold standard diagnostic pathway, the 2-week wait pathway across 5 different specific areas. And I'll go into that later in more detail in a minute. So there are a couple of issues around how you do tests like this. So cancer's more common in populations that are socioeconomically deprived and who engage perhaps less often with healthcare as it's currently configured. So one of the issues with introducing new tests like this is to make sure that we get them to the populations and the people who are most likely to benefit from that. And that's taken quite a bit of work, and colleagues at King's who've been doing the larger population-wide study have put a lot of effort into that, about how you get to people and persuade them to come to a blood test who don't engage with their doctor at all, or very infrequently. The other concern we have is that if you have a test that's negative, does that then influence your subsequent behavior in reporting symptoms? Because if one's being very precise about a negative test, what it says is that there's a low probability that you have a cancer on the day of the test and nothing more. And if a new symptom develops in the following weeks or months, then ideally one should discount that in assessing the symptom and deciding whether to consult a doctor, a pharmacist, a nurse about whether to take it further. The other concern we have is the flip side, which is that if you do this to everybody, you risk making everybody a patient rather than just a member of the public. There will be false positives with these tests, and I'll talk about them in a minute. And then finally, with these positive tests, they're not definitive. We still have to go on and do other tests in order to decide what exactly is going on and to diagnose a cancer if a cancer is indeed behind the positive test. And we need to understand the level of demand for additional tests, CT scans, biopsies, endoscopies, and so forth, that will follow from rolling the test out, and work out whether we as a health service can adapt to that demand or whether it's going to sink us, particularly at the moment when we're under so much pressure. So with the big Gallery study in the asymptomatic population, as I said, it's very, very large, over 100,000 participants. And essentially, if we find a positive signal, We're going to plug people into the existing diagnostic pathways, cleverly misspelt there in my slide, and make a diagnosis of cancer in the usual way. And then what we want to understand is, have we detected these cancers earlier using the stage 1, 2, 3, 4 at the time of diagnosis as the basis for that assessment. And this study is now fully recruited. People are starting to come through. I think, I'm not closely involved with the trial, for their second blood test. And I think we can expect some results in the next year or two that will guide the use of this test more widely across the NHS. With Simplify, this is a smaller study. There are 6,000 people in it, just over, and they've either come to a rapid diagnostic pathway because they've got non-specific symptoms their GP is worried about, might be down to cancer, or they've been referred to one of 4 pathways looking for lung, gut, or gynecological cancers specifically. And we took the blood test at the time they came for the tests on those established pathways, and we're comparing what the test says is happening with what the standard investigative pathway says is happening. And the question we're asking for the longer term is, could we bring this test in instead of scopes and scans, which are the basis for the tests that we do in the 2-week wait pathway at the moment, because that would obviously be much less invasive and troublesome for the vast majority of people who enter these pathways and turn out not to have cancer. If we think about the promise and the pitfalls of this sort of approach, then clearly the great potential is our ability to diagnose cancers earlier, but it's going to come at a cost. There's a financial cost, the cost of the test itself, although hopefully that, like most tech-heavy things, should get cheaper over time. There's the cost to the service, the NHS in this instance, of doing the tests that go in and around it, as well as organising this. Obviously, it's very different from relying upon people to present to their GP with a symptom to suddenly going out and actively looking for cancer using a blood test right across the whole population. And raises questions about how often should we do it and so forth, as well as what other tests will then follow from the blood test. And then there's the cost to people. We're asking people who aren't patients to engage with the health service through the blood test, and we're going to make some of them patients, including some of them unnecessarily so, and create anxiety and concern and so forth, as well as identify cancers earlier. And then what we really need to understand is whether this is something that we bolt on to what we're already doing, or whether this is going to completely change everything. Now, I'm talking for far too long, so I'm going to speed through the next couple of slides to make sure I don't eat into Sue's time. Just a couple of points to make, really. But if we're thinking about screening healthy people in whom much less than 1% have a cancer, and the tests have false positives, then just to think a little bit about that. And people have got quite smart about this because of COVID and the false positives and so forth around COVID tests, like lateral flow tests. But let's say 0.5% of people have cancer, then our test will identify 5 people with cancer amongst 1,000 people tested, as shown by the rings here. But then again, if we've got a 0.1% false positive rate, so one test in 1,000 is falsely positive, then that means in 1,000 people we'll get 6 positive tests, but fully 1/6 of those tests will be falsely positive. So it puts into perspective the relative burden from a positive test, particularly if you start to do that across hundreds of thousands of people. That's an awful lot of people being told they might have a cancer, or we think they have a cancer, who subsequently aren't going to. And if we think about the converse, about using the test to say you don't need further tests, then in a pathway where only 4 to 6 people have a cancer when they go in to have their scope or their scan, then a test that's 90% accurate, which sounds pretty good on paper, is only about twice as good as the current testing, and still leaves that significant risk of a lot of people being told they're okay when they still have a cancer. So it makes it a very, very complicated series of trade-offs and definitions for test performance before we can roll this out on a big scale. But the advantage of that, if we can get it right, is that we can start to break this barrier between having to either screen people or wait for them to get symptoms. Because if we can use a blood test as the first test of whether you need to have something more invasive, then we can be much more generous, if you like, or really widen the net of people who go into these pathways in the first instance. Because if it's just a blood test and you get the answer back within a week and that may stop it, then maybe we can have 10 or 20 times as many people going into these pathways in primary care, and the test being used as the sieve for who gets the scans and so forth. And that will then give us the opportunity to really shift the dial in terms of non-specific symptoms and identifying who really needs investigations to diagnose cancer early. So to sort of summarize the situation, this is potentially very, very disruptive in a good way to current practice. It also has other applications across cancer, monitoring people on treatment or telling us in more detail about the cancer, not just where it came from. There are lots of competing technologies, which means it's going to be quite a bun fight over the next few years to work out what the best technologies are and how best we implement them. But I think we also have to be very careful about overselling these tests. They're going to be a useful weapon in our fight to diagnose cancer earlier, but they're not going to be something that takes everything over and does away with everything that we do. There are still going to be very important issues to overcome before they're ready for prime time and at scale. I've run out of time, so I won't talk about how we could apply this globally across the rest of the world, other than to say that this is a way of leapfrogging the lack of some of the technologies we take for granted here in the UK, so that we can use blood tests to diagnose cancers, for example, in sub-Saharan Africa, which one of my colleagues, Anna Shu, is doing at the moment in East Africa. And if you want to hear more about that, then there are pages on the Oxford Cancer website that you can have a look at and see that. So in summary, this has got a huge potential to change the way in which we screen for cancer and to become an alternative to invasive tests, which will fundamentally change the way in which we diagnose cancers. I think it's also a way in which we can enhance productivity. And there's a lot of talk about the NHS's bottomless pit and so forth. But clearly, we can get through a lot more people and help them to understand whether their symptoms indicate serious disease or not by using a blood test versus using things like CT scans and scopes, which require lots of people to deliver them and lots of expertise that takes years to train. So overall, I'm extremely optimistic about the ways in which these blood tests that can detect multiple different types of cancer are going to change the NHS. And I think we've got an exciting few years ahead.
Fantastic. Thanks very much, Mark. That was really fascinating. And I'm sure, well, it's already prompted a couple of questions, which we'll put at the end after we've heard from Sue. But if anybody else has questions for Mark or Sue, please pop them in the chat and we'll ask them at the end. So I'm going to hand over to Sue Duncombe now to talk about what this might mean from a patient perspective. Over to you, Sue.
Thank you, Roy. As Roy said, I'm a member of the public who's involved in various health research projects. My declaration of interest is that I'm on the steering committee and a patient advisory group for the company Grail for the Gallery study that Mark explained earlier. The area that I'm most passionate about is improving the early diagnosis of cancer. And diagnosing cancer early can save lives. And if we take the example of bowel cancer, for people who are diagnosed early, then more than 9 out of 10 of them will survive for at least 5 years. Unfortunately, if they're diagnosed late, then that figure drops to less than 1 in 10. And I know from personal experience what a difference early diagnosis makes. Let me introduce you to my family. My dad was diagnosed early with prostate cancer, and then 5 years later, he was diagnosed early with stomach cancer, and he survived both of them. Unfortunately, Mum had some more non-specific symptoms, and particularly weight loss. She was diagnosed late with gynae cancer. 6 months after her diagnosis, she died. My husband, Philip, was diagnosed with prostate cancer and died in his mid-50s, less than 5 years post his diagnosis. So late diagnosis can absolutely devastate families. We need to diagnose cancer early when it can make a difference. And whilst I believe these blood tests, multi-cancer early detection tests, hopefully will have a role in screening, because of limited time today, then I'm going to focus on where I see the potential and the benefits to patients in terms of using them as a diagnostic tool. So let's think of someone who has some specific symptoms that they think may be cancer and go to their GP. It could be a lump, or it could be blood coming from some place that we're not meant to be getting blood. These things are classified as red flag symptoms. In that situation, the GP would refer the patient to the relevant hospital department. That department would do further tests and hopefully be able to diagnose what's wrong. For many patients, it won't be cancer, but for the ones that do have cancer, they can then begin treatment. But what about the patients? The ones who Mark mentioned are actually, some of them are in the Simplify study. The ones who don't have those specific symptoms, they have very non-specific symptoms that could be one or a combination of the things that I've listed here. Let's say it's something like there's unexplained weight loss. They're feeling fatigued. They just don't feel quite right. It's difficult for the GP to know if there's a significant risk that they have cancer, because these symptoms could be due to a wide range of problems. And if the GP does believe there's a reasonable risk of cancer, then how do they know which hospital department to refer them to? I said they could be due to a range of underlying problems. So let's say the GP, from the information they've got, makes a sort of logical assumption and refers them to a specific hospital department where they're investigated. Unfortunately, that department actually doesn't find any problem with the patient. So they're back to the GP, and then probably back to another department for further tests. For these patients, they feel as if they're in a revolving door. They're going round and round and they're getting nowhere. During this time, there's uncertainty, there's anxiety. And the more time passes from when that patient gets their initial non-specific symptoms to getting their diagnosis, then the more that anxiety increases. If the GP could do a blood test, which gives an indication as to the level of risk of the patient having cancer, then that would help GPs prioritize which patients need further investigations for cancer. It would also help reassure others that they probably don't have cancer. But it could also help remove some of that uncertainty.
I'm just sending you email now. I'm unsure.
Excuse me, could everyone turn their, make themselves mute? Thank you very much. So it would also help the GP, because as Mark said, then the idea with these tests, as well as giving a indication as the patient might have cancer, it also gives an indication of the location. So consequently, the GP would have better information to know where to refer the patient. And for the patient, it can mean getting rid of that revolving door and getting a diagnosis earlier. And in some centres, in some regions, there are centres called community diagnostic hubs or community diagnostic centres. And these are effectively one-stop shop where the GP can refer a patient that they suspect have cancer. The patient can undergo a range of tests. And I see that these are a huge move forward. But even in this situation, if the GP could do the blood test, again, it would help them prioritise who to send to those community diagnostic centres. And perhaps particularly for some of the cancers that Mark mentioned that currently are identified, they're diagnosed late, cancers like pancreatic, ovarian, esophageal, where the outcomes for patients are really not that good, primarily because of late diagnosis, then perhaps these tests could help there. So I believe that there is great potential from these multi-cancer early detection blood tests to help improve diagnosis. And I'm pleased to see that some of the points that I've got here actually agree with Mark's summary. So I see that it could help GPs prioritise which patients to send for further tests. And other patients could be reassured that there is really a very, very low risk that they have cancer. For some patients, it could reduce that time to diagnosis, which means it may improve the potential outcome and treatment option for any patient who is diagnosed with cancer. But also, it could reduce that time from when the patient first presents to the GP to the time when they get a diagnosis. And importantly for those patients, it would reduce that time when there's uncertainty and anxiety. And Mark mentioned that these tests will be disruptive, but not necessarily in a negative way for the NHS. And potentially it could focus NHS resources. So the right patients are more likely to get the right test at the right time, and potentially patients could also, we could reduce the number of patients who are undergoing unnecessary diagnostic testing. And I'm left wondering if these tests had been available some time ago, whether the outcomes for some of my family members might have been different. For me, research is where hope starts. And these blood tests currently offer hope for patients. But we need to wait the results of the large studies, both the Gallery study and the Simplify study, to see if that hope is fulfilled. Thank you.
Thank you, Sue.